A very warm good evening to our esteemed dignitaries, faculty members, and dear delegates. Myself, Dr. Navya Gangadharan, Assistant Professor in Community Medicine, and it is my absolute privilege to serve as a coordinator for today's webinar. On behalf of the Department of Community Medicine, KMCT Medical College, I welcome you all to this national webinar on leprosy eradication in India, status and strategies. As we move closer to the National Strategic Plan's target of interrupting transmission by 2027, today's discussion is not just academic, it is a roadmap for our future as healthcare professionals as well. Before we begin, please ensure your microphones are muted. We encourage you to drop your questions in the chat box. We'll have a dedicated Q&A session following the presentation. A feedback form will be circulated at the end of the session. Please feel free to share the valuable feedback with us at the end. I now request Dr. Jayakrishnan T, Head of the Department of Community Medicine, KMCT Medical College, to deliver the welcome address and set the context for today's session. Over to you, sir.
Good evening to all. Today is January 30. January 30 is World Leprosy Day. January 30 is also the death anniversary of Mahatma Gandhi, the father of our nation, India. He taught us that his life was his lesson. It is the day for remembering his martyrship. He believed that service to persons with leprosy who are stigmatized during the days, even now they are also stigmatized. And stigmatized persons on those days was a moral responsibility and was a social duty, not as charity. He actively nursed people affected with leprosy. In Sevagram Ashram at Varda Ashram still remains evidence of his historical relic. I have a luck to visit that ashram during the IAPSN conference in 2002. Dedicated to his work for leprosy patients and overall leprosy, since 1954, whole world is observing Leprosy Day on January 30th. Even now, the attitude towards leprosy is same. Even now also in the 21st century, leprosy is a neglected tropical disease. And leprosy persons are also stigmatized. I think maybe because of this, even though there are available tools, we cannot utilize it properly. So we are not able to eradicate leprosy. Globally, our nation, India, still contributes 60% of the new cases as per the new World Health Organization reports. That means from India itself reported cases more than 1 lakh yearly. And of this, 7 to 8% are child cases. That means there is still transmission in India. In some part, it is comparatively, some states are less and some other part, it is more. And out of this, grade 2 disability in the freshly reported cases are up to 5%. That means there is late detection. And coming to Kerala, we have got average annual incidence rate of 300 to 400 cases. Among these, 20% are interstate migrants. And so this year, in 2026, this day, January 30th, we are conducting this seminar. This seminar is our fight against the stigma, and this seminar we are conducting as our fight against discrimination. This seminar we are conducting this day as fight against neglect. This day reminds us that scientific program must go hand in hand with human values. So I will go to the welcome speech. In their absence, I first welcome Dr. Nawaz, Chairman, Managing Director of KMCT Group of Institutions, and Dr. Vijesh Gowal, Principal of KMCT Medical College, who both supporting us for conducting this program. I welcome Dr. Rajaram, District Medical Officer, Kozhikode, under whose leadership activities are conducted in the whole district and who happily accept our invitation and will inaugurate our national webinar. Next, I welcome Dr. Kumaresan, the key speaker in this session, who is also a former Joint Director of Center of Leprosy Training and Research Institute, Chinkalpet, Tamil Nadu. Welcome, Dr. Kumaresan. Next, I welcome Dr. Lathika, Deputy District Medical Officer, Kozhikode, and who is also in charge of National Leprosy Eradication Program at Calicut. Next, I welcome all the faculties, postgraduates from all over India, the medical officers, especially from Kerala State, and medical students from all over India who are participating in this program, PG students, and welcome to my own family members from KMCT Medical College. A welcome to my colleagues from Department of Community Medicine. Next, I welcome Dr. Navya, Assistant Professor, Community Medicine, KMCT Medical College, who is coordinating this program and for coordinating the program and giving instructions as well as inviting our chief guest for inauguration. Over to Dr. Navya.
Thank you, sir, for those insightful opening remarks. We are grateful that Dr. Rajaram, sir, District Medical Officer of Kozhikode, has joined us today. Sir, we warmly welcome you for the inaugural address.
Sir, he's traveling by train. He wants to continue the program. He will join when internet is ready.
Okay, ma'am. So moving on to our first technical session, it is my honor to introduce Dr. K Kumaresan. Dr. K Kumaresan, sir, is a public health specialist in Central Health Services, Government of India, and was previously working as the Joint Director in Central Leprosy Teaching and Research Institute, Chengalpattu. CLTRI is a Government of India institution under the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, established for comprehensive leprosy care services, training and operational research in leprosy and for the implementation of National Leprosy Eradication Program. Sir did his MBBS from Coimbatore Medical College and post-graduation in MD Community Medicine from Government Medical College, Kozhikode. Before joining CLTRI, he had worked as a teaching faculty member in the Department of Community Medicine at various medical colleges in Tamil Nadu. As a senior public health professional with diverse experience in leprosy program management and capacity building programs, he has made significant contributions to the national efforts under the National Leprosy Eradication Program. He has also served as a resource person for various trainings and workshops conducted under the National Leprosy Eradication Program at the national, state, and institutional levels. He has involved in drafting of the NLEP program guidelines and contributed as a member to the National Strategic Plan and Roadmap for Leprosy Elimination 2023-2027. At present, he is dealing with the port health surveillance and management and international health regulations. Today, Kumaresan sir will enlighten us on status and strategies for leprosy eradication, India's NLEP roadmap. Over to you, sir. Yes, sir. Yes. Thank you, sir.
Yeah, thank you. So, good evening to all. Dasmai Sri Guruve Namaga. I am grateful to Jay Krishnan sir for having invited me for this webinar after so long years. On this World Leprosy Day. Actually, it is National Anti-Leprosy Day. I thank you, sir, and the faculty of KMCT Medical College and other dignitaries, and also the District Health and Family Welfare Kozhikode will be also participating in this webinar. So, without not taking time, I will just dwell into my presentation. The topic is Status and Strategies for Leprosy Eradication, India's NLEP Roadmap. So this will be the context for next 30 to 40 minutes, where I will touch upon the brief epidemiology and transmission dynamics of leprosy, status of leprosy at global level and national level, National Leprosy Eradication Program and updates, strategies for leprosy elimination, and the National Strategic Plan. So, what comes to mind when Hansen disease or leprosy is actually seen or observed or detected actually. So leprosy is seen as a disease with patches and nodules and the gray faces, deformities, the most important thing. And we could see people with deformities begging for alms at the railway station, bus stand, and everything. So this is actually a old phase of leprosy, which we want to forget. And this is the one which has been there in the past or from the ancient periods. We try to change these things. So many programs or strategies has been there to reduce, as said by sir, to reduce the stigma. So we are also planning to change the face of leprosy from the old one to the newer one. So the end we'll be also seeing that thing. So with that, so it is a disease which has affected humanity from the ancient times, and it has left a terrifying image in the history actually. So where we could see in the ancient literature also the mention of leprosy or Kushtarog, or in various other names are there. And it is one of the neglected tropical diseases which is reported in more than 130 countries. It's not about India, Southeast Asian countries or other. More than 130 countries report a new case of leprosy. You all know that it is a chronic infectious granulomatous disease which is caused by Mycobacterium leprae, M. leprae. Other things are also there, other epilomatous also they may involve in the causation of leprosy. The most important thing with leprosy is the disability which it causes. The stigma which is attached to the disease, it is not to the bacterium or it's the any other bacterium which causes, but the stigma part is actually more with leprosy. It is the grave disabilities which is caused by the bacterium and its consequences, which is the major reason for stigma. So once the disability is actually prevented, we could prevent the major part of stigma actually. So that is the most important aspect in our program also, preventing the disabilities or preventing the deformities. So that will go a larger one in preventing the stigma. You all know it's not only a medical problem, it has got social consequences and also the economic issues also, where a person affected in the productive age group, losing his wages, losing his life, and they are thrown out of families also. So it's a social and economical problem which needs to be seen in a comprehensive manner, where medical part is the treatment is there, social part, socio-economic measures should be there. So it has to be a compassion of all aspects. And elimination of leprosy as a public health problem has been attained in India. So that I will come to this back actually. So a basic epidemiology where I don't go details into the thing. One thing is that as far as India is concerned, humans are the source of infection. The extra human hosts are available in other countries actually, where in Americas and other African countries actually, these armadillos, monkeys, they actually harbor the organism. They are involved in the spread. Whereas in India, the extra human host is not reported. The incubation, you all know that incubation period is very long and it is variable also, where we say that average of about 5 to 7 years. And it can affect any ages, where there is a two peak, younger age group is also affected and the older age group is also affected, whereas double peak is there. And it is a spectral disease. It depends upon the immunity in the person, where the consequences of the disease is getting up, right? One part we have tuberculosis spectrum and another part you have the lepromatous spectrum. In between you have middle both. The important aspect is that it has got a low pathogenicity. Only small proportion of the persons who is getting infected develop the disease. Whereas when you compare with its the sister bacteria, Mycobacterium tuberculosis, it is actually higher, where the pathogenicity is actually higher with tuberculosis. Whereas this is the same Mycobacterium group, whereas the gene of this Mycobacterium leprae is decayed to have the consequences, the infectivity less. And we don't have any reliable tools to diagnose the subclinical infection. And this is one of the first mycobacteria to be discovered under a microscope, 1873. even before Mycobacterium tuberculosis. But still, we don't have any tools to diagnose subcutaneous infection, or it could not be cultured in an artificial media where an effective vaccine is still elusive for leprosy. And deformities we have seen. And the other thing is that the burden is hidden, where many of the cases is actually submerged. What we see is tip of iceberg, and there is clustering of cases with various endemicity, right from the block level, state level, or at the national level. And next, contacts are at the higher risk, and the socioeconomic factors also play a role in the transmission of leprosy. So that is the dynamics. So transmission model from exposure to infection. So it is actually less. The pathogenicity is less, where 5 to 10% may get infected with the bacteria, and 1 to 2% may go on to develop a disease from infection stage. So, and it depends upon the time and incubation period, how much they get the dose, and based on the dose, the infection and the disease is determined. So infection, it depends upon the dose of bacteria which we get, and the BCG vaccination status, environmental condition, how much they stay alive and have the virulence in the environmental. So that is also plays a role. And mostly it is asymptomatic. 80% there is a self-healing process is there. Rest only go on to develop the disease based on their immune status, depending upon the age and sex, where it is 2:1 in terms of gender, and genetic factors play a role in that. And the most important thing is the contacts, the close contacts, where they are at the risk of getting the infection, and they move on to the disease part. So here the disease means the presence of the hypopigmented patches, involvement of the nerves, and presence of the acid fast bacteria in the triple-S, slit skin smear. So based on that, it is diagnosed, and it is classified into possibacillary and multibacillary type. So treatment, we have MDT. So this is the transmission model for leprosy. And this is the definitions for leprosy, where they have these cardinal signs, and they have not completed any course of MDT. So hypopigmented patch, there should be a definite loss of sensation, involvement of nose, and demonstration of bacteria in the lesions. So this is the cardinal signs. Coming to classification, that has been recently revised from April 2025 as far as India is concerned. So possibacillary is 1 to 5 lesions, multibacillary is more than 5. Peripheral nerve involvement, so that when there is no nerve, it is a case of PB. When there is 1 or more nerve, it is a case of MB. Likewise, skin smear, it is negative in PB cases, and it is positive in MB cases. So coming to treatment also, we have revised the treatment part. Previously, we had 4 color-coded blisters, actually, blister calendar packs. Now it has been reduced to 2. Based on the scientific evidence which has been generated over the years, WHO has also recommended for this addition of clofazimine for the PB cases. Previously, the drug clofazimine was not for PB cases. Now, clofazimine has been added into the regimen. So it is now uniform. So it is rifampicin, dapsone, and clofazimine. These are the first-line drugs which are used for treating leprosy. So these 3 drugs are used for both PB and MB cases. Only thing is that the duration differs. The duration of treatment is 6 months for PB, and it is 12 months, 1 year for MB cases. So duration differs, whereas the blister remains the same, having the 3 tablets. Adult and child doses vary. Where adults, we have 600 milligram rifampicin once a month, dapsone 100 mg, clofazimine 300 mg once a month. So child-wise, there is a reduction of doses for the child. So we have now 2 blister packs which has been revised this year. The cases are again classified into new case or the other case. A new case, the one who has not taken any treatment. Other case, those has been previously treated with MDT, multi-drug therapy, and they need MDT again. So they are put it into other case in the program. As far as program, it is the new case and it is other case. 85 to 90% it is the new case in the program. So 5 to 10% it is the other case. So 5 to 15. So this is the recommendations by World Health Organization on guidelines. This was the first one where it is based on the guideline development process. So as far as diagnosis is concerned, it's purely a clinical diagnosis. with or without skin smear or pathological examination in terms of biopsies. So it's a purely clinical examination, and we don't have any test or no test is recommended to diagnose a subclinical infection or asymptomatic contacts. Treatment, now we have discussed, it is the 3-drug regimen for both PB and MB cases. So these are the first-line drugs. And if there is any resistance or who develop side effects to the first-line drugs of rifampicin, dapsone, and clofazimine, we go for the second-line drugs like erythromycin, minocycline, and fluoroquinolones along with clofazimine. So they are used for the second-line drugs. And now we have a tool to prevent the leprosy among the contacts. So that is, with a single dose of rifampicin, we can prevent the transmission of leprosy among the contacts. So that is also one of the tools which is actually now promoted for reducing the burden of leprosy. It is a single dose rifampicin. So what is called chemoprophylaxis. So that was a basic of leprosy. Now coming to the burden of leprosy. So you can see that before introduction of MDT, there were about 12 million cases. And after introduction of MDT, there was a drastic reduction in the burden of leprosy, where it reduced to 50 lakhs. So over the years, we have reduced the burden, and now we stand at a little above 1,70,000 cases. So that is the global burden of leprosy, where you can see that the dark ones are the one which are the tropical countries, where more than 10,000 cases or 1,000 cases are reported. So that is the countries which are reporting more number of cases. It is in the Southeast Asian countries, America, where Brazil and Argentina, they report, and next is the African region. That's the sub-Saharan countries where they report more number of leprosy cases. So that is at the global level. Definitely, we have reduced nearly 25% from the last 10 years. The burden we have reduced in terms of the absolute number of cases. So the priority countries for leprosy burden. So we have 23 priority countries where they report 95% of the cases. Of these 1,72,000, these 23 countries, they report 95% of the cases. Among this, India, Brazil, and Indonesia, they constitute around 80% of these cases actually. So for the world's progress to achieve a world free of leprosy, or to reduce the burden more, what we need is the progress which is made by these three countries, and moreover, it is the India, where nearly 60% of the burden is contributed by our country, where little above 1 lakh cases are reported in 24-25, and Brazil second, Indonesia. And our neighbors also report Bangladesh and Sri Lanka, Nepal. They also report around 3,000 to 2,000 cases. So the next one is the grade 2 deformity cases. Grade 2 deformity is simply which is visible. The deformity which is visible, like your claw hand or foot drop, any ulcers or facial deformities. So that's the one what we called as grade 2 deformities. So in terms of grade 2 deformities, we report 1,800 cases, which is 20%. Whereas other countries, if you see Brazil, the grade 2 deformity reporting is actually higher, nearly 25%. So that is the priority countries for WHO. Our success will depend upon how these 23 countries, mainly how we progress on in reducing the burden. So that will lead to the global reduction of burden. So coming to our country's status, previously we have said that India has achieved elimination of leprosy as a public health problem. Many people thought that that elimination as eradication. Leprosy is eradicated. Yes, definitely case numbers has reduced. We have reduced more than 98% of the burden from 1980s. But still, the cases are occurring. We could see that in a day, more than 275 cases are reported in the country, with one case detected for every 5 minutes. So still the cases are reported, transmission is happening, cases are reported, but it is not even in among the states or at the district level. So it is some clusters it is more, some clusters it is not that much a problem. But still the cases, new cases are reported in the country. So we have attained that level of prevalence. That is the most common indicator which we use epidemiologically, prevalence rate. So what the target which has been kept by WHO and the World Health Assembly, 1991, to reduce the prevalence to less than 1 by 2000. So that was a level where we have declared this an elimination of leprosy as a public health problem. So we have reached that level in December 2005, where it is 0.9, we have reached in December 2005. So that's where we stated as prevalence is less than, for 10,000 population, it is less than 1. So we could see that 2024, we stand at 0.57, and the new cases, the incidence of the cases, new cases for in a block of around 1 lakh population, it is about 7. 7 new cases are reported in a population of 1 lakh. So that is the new cases, what we called as annual new case detection rate. So that is the burden in our country. So 2000, I am more particular about this 2019-20 because so I would split it here pre-COVID and post-COVID era. So 2019-20 we had 1,14,000 cases with a new case detection of 8 per lakh. The child cases stood at 7. So at that time, 2 states have prevalence more than 1. It is Chhattisgarh and Odisha. Whereas in 2024-25 last year, we have 5 states and union territories. There is addition of Jharkhand, Maharashtra, and Chandigarh, where the prevalence is more than 1. So these 5 states and union territories still have a level at the state level. They have a level more than 1. So these are the common indicators which we use in the program. KNCTR is annual new case detection, prevalence, child cases, grade 2 deformity, percentage. So this is the burden as far as 24-25 is concerned, where 8 states contribute to 80% of the disease burden, with Maharashtra, Uttar Pradesh, Bihar, Madhya Pradesh, Jharkhand, Chhattisgarh, and Odisha. So they contribute around 80% of the burden, where you can see on the right-hand side, it is very less. So those states, which are smaller states also, or union territories, they move on to the next level, what we called as from elimination. So it will go on to the next phase of elimination. I will cover in the latter. So this is actually an older one, 2019 statistics, which is where we have done an analysis based on the composite indicators of prevalence, new case detection, child case reporting, and grade 2 deformity, where you can see the ones which are in the red. So that's where the more number of cases are concentrated. Central part of India and some northern part. The yellow, it is a moderate endemic districts. Green, it is the lower endemic districts. So gray, it is the sporadic cases. So still it goes good because again, we are standing at the 2019 level after COVID. So progress, definitely we have progressed a lot from 2000 to 2025. So 2000 to 2005, so that was a period where we have more number of cases. And 2005, before 2005, we have more number of active case detection campaigns. And there was also change in the terminologies also. So by 2005, we have achieved the level of less than 1 per 10,000. So I would see here as from post elimination level 2005. So 2005, last 20 years, new case reduced by 27%. Child cases we have reduced by nearly 67%, and grade 2 deformity we have reduced by 40%. So there are major achievements, significant achievements in our national program. The worrying thing which has been there is that after 2005, so the new case detection remained at the same level. It varies between 1,20,000 to 1,30,000. So that was the scenario, and 1 lakh. Say 15,000. So that was the one numbers which are hovering around. The one which you see here, the lower one. So it is a grade 2 deformity. When you compare these two things from 2005, it can see a stable line. Whereas this one from 2%, it has increased. It has increased in 2014-15 to nearly 5%. So this is where something is happening at the ground level, where cases are reported, but the grade 2 deformity is going up, which shows we are detecting the cases late. Transmission is still there in the population. So we need to put on some other measures to pull down the graph to down. So various new initiatives were taken up during that period of time. So we will be discussing that at the later part. So that was the scenario of our country for the last 20 years. So this is the southern states. Kerala reports around 366 cases, which is as the least, NCDR of 1. Karnataka with 2,200 cases, Tamil Nadu 2,700, Andhra Pradesh 3,400, Telangana 2,300 cases. So that is the situation at the southern states. This one, we could see that what we have seen is the numbers which has been reported to the national program. The numbers which is diagnosed at the PHCs, CHCs or the medical colleges. So those are the numbers what we have seen, these 1 lakh cases in 2024. So those numbers are the one which are reported to the national program. Here, you see on the right side. So this was an estimate, still a older one, which is nearly 10 to 15 years old. So this was the estimate. After that, we have not gone for any estimate for leprosy cases. So that was taken up by ICMR, Central Leprosy Division, Ministry of Health and Family Welfare. Those estimates put that there are 3,30,000 cases. What is reported to the program in the corresponding period is 1,25,000. So in the field, we could see that 2.5 times the number of cases is actually higher when compared to the one which is reported to the national program. Tamil Nadu, it is nearly 4%. Kerala, it is somewhat near. It is only about 1 times higher. So this shows that the burden is actually submerged. What we see is the tip of iceberg. Majority of the cases are hidden. These pads, which is painless, they don't bother them. So they report whenever they have some issues to the health centers. So that is actually causing this submerged one, the numbers which is actually lower. So that was regarding the problem. So coming to the program, after independence, we have launched many public health programs. Out of that, National Leprosy Control Program is the most important thing also in that our Government of India programs. So 1955, it was started as a control program. Then 1980s, we saw introduction of MDT. Previously, only Dapsone was there from 1955, 1940, and to 1980s actually. Only Dapsone, lifelong, they have to take. So 1980s, we saw introduction of rifampicin and clofazimine. So we have just combined and it is put it in the form of MDT, multi-drug therapy. So after introduction of MDT, the case load has actually reduced very significantly. So then the program, we thought that from control, we can go to the next stage. So control, we have gone to eradication actually, National Leprosy Eradication Program. So with the introduction of MDT in 1983, the program changed to NLEP, Eradication Program. So from 1988, we saw a phased introduction of MDT after that. So from 1988 to 2004, we have many active case detection campaigns, what we call Modified Leprosy Elimination Campaign, Special Action Project for Elimination of Leprosy, block level awareness campaigns also. Various campaigns were there. And 2005, that was the landmark year where we achieved a level of less than 1 per 10,000. At that time, this NRHM came, present day NHM. So there was a gradual integration of NLEP services. It was a vertical program. Then it is made into an integrated program with a general healthcare setup. So 2006, we have this disability prevention and medical rehabilitation guidelines. What we have seen in 2015, our rate of grade 2 deformity has actually increased. So we need to put some measures to reduce that thing. We have to take some course correction in that level. So course correction in the program was taken in 2015-16. Various new initiatives was launched with the program. And now recently we had this National Strategic Plan and Roadmap. So objective of the program is to reduce the level less than 1 in all the districts. So 85% of the districts we have reached. Still, again, we have gone to the square one of 2019-20 levels after COVID. Grade 2 disability to less than 1, which is nearly 2%. And 0 disability among child. Still, we have children. We don't want our child to get leprosy. And more than that, we don't want our child to get disability due to leprosy. So that is a very, very worrying thing actually. So we want to reduce that to 0 and 0 stigma and discrimination, where we have the laws from the colonial period, which are very regressive also. So the government of India has taken steps, state governments also taken the steps to repeal those laws, and nearly 70 to 75 laws still remain to be repealed. So these are the strategies for the program, where it is now a decentralized program, which is integrated into the general healthcare system, where a PHC staff who look after the other programs, in addition to the 2025 programs, they have to look after leprosy program also. Early detection and complete treatment, it is the key, where we have to detect the cases early and put on treatment. Carrying out household contact survey, because contacts are at the higher risk. Capacity building, the expertise to diagnose a case of leprosy, because it depends on the clinical skill. The case numbers has reduced. Definitely, the expertise to diagnose a case of leprosy is also reducing. So in that scenario, we should have, or to maintain an expertise, we need to build the capacity. Training and retraining of our healthcare workers is done for that. Involvement of ASHAs at the field level, strengthening our DPMR services, an enhanced IEC program, which is also carried out, and monitoring of programs. So these are the functional domains in the program where there is a case detection. It is by active measures and passive measures. Both play a role actually. Active measure is that we go to the house to house, search for the cases, case suspects, and then for the cases. So active measures, various active measures like contact tracing, like leprosy case detection campaign, and the school screenings. So that happens by the active measures, whereas passive surveillance is also playing a bigger role. In a long run, what we need is strengthening our passive surveillance system, where the health facility screening or the voluntary reporting of the cases to the hospitals. So that's where we can have more number of passive surveillance. So that is case detection, treatment, and the most other important thing is also partnership and collaboration with our partners like NGOs, private providers who play a role. They go to the private providers first, then they report to the healthcare system. So that is also more important here. So this is the one which we are speaking about in the previous slides also, where in 2015-16, we have launched the new initiative in the program. So we have improved on our indicators from 15-16-20. Then there was a health emergency, COVID came. It's not about leprosy also. Other programs also suffered. There is a reduced case detection activity where the healthcare workers have actually moved to the other programs. So that was the scenario, but still we are able to come out of that setting, and we have reached a level where at the pre-COVID level, but that has derailed our targets and goals in a longer run. And after that, we had a reintroduction of LCDC in 2023, and NSP was there. So these are the new key initiatives which are launched in the program, where we had a three-pronged approach to detect the cases early, what we call LCDC, Leprosy Case Detection Campaign, FLC is Focused Leprosy Campaign, and Special Plan for Hard-to-Reach Areas. So that was our major strategy. And second thing is the ASHA-based surveillance. ASHA-based surveillance for leprosy suspects, NICUS reporting system, investigation of grade 2 deformity cases, Spush Leprosy Awareness Campaign. So we are in the midst of Spush Leprosy Awareness Campaign. Today is the Anti-Leprosy Day. That is the January 30th to commemorate the death of our Mahatma Gandhi, father of nation. So from now, 2 weeks, it is continued as Spush Leprosy Awareness Campaign, where we create awareness of leprosy by Spush in this program. Then we have contact screening and post-exposure prophylaxis single dose rifampicin, and convergence with the NHM program. So LCDC, coming to LCDC. So it is a 2 weeks of activity where the volunteers, male and female volunteers, go to the houses in search for leprosy suspects. They do physical examination of each and every family member of the targeted population, identify the suspects, and refer to the PHC or subcenter for the diagnosis. In the form, an IEC is also generated at the higher level. Supervision at all aspects is happened. Recently, the state of Kerala has actually concluded on round of LCDC, Ashwamedham, where the case detection part in the form of LCDC has happened. And the focus leprosy campaign, this is for the high endemic districts. Focus leprosy campaign, it is for the low endemic districts. When you report a case of grade 2 deformity, then we do surveys in the village level. If it is in the urban areas, it is 300 households. Then we have special plan like in the tribal areas or for the migrants, urban slums, where we could not, the normal routine systems could not reach. Then we need to have a special plans to reach those areas for detection of the cases. This is ASHA-based surveillance, where we give incentives for the ASHAs for case detection, 250 rupees. Then for treatment completion also, incentives are given to the ASHAs for the treatment completion. Then contact screening, this is one of the targeted and active surveillance measure. COVID, we know more about this contact tracing and screening and all. Even before the COVID, we have this contact tracing method in the leprosy program, where we trace the contacts of the close contacts of the index cases. It is not an what you called a Pakan number. It is not absolute numbers also. We keep this as an operational definition of 20 hours per week for at least 3 months. So that is the close contact defined in the program, where they have a higher possibility of the contacts developing leprosy infection and to have the disease. So it is the household contacts which are very close, neighborhood and social contacts. So we do repeat contact tracing for the family members who had the case. Then we have retrospective also. We trace back to the 5 years. Then we see the contacts also. Then reverse contact tracing. We try to identify the index case from the reported cases. So that is contact tracing. Special leprosy awareness program we have seen. And this is one of the public health program which has reached the grassroots levels of our democracy. Yes, special Grama Sabhas is convened at the village panchayats to create awareness about leprosy, to involve the persons affected with leprosy in the program, and involvement of the district administration into the public health program. So definitely from 2017, it has created a huge awareness activity and also in the case detection efforts. So our idea is to promote community participation to reduce the stigma and discrimination which is associated with the disease. So various other line departments also involved. Not only the health department, education department is involved, revenue department is involved, social welfare department is involved. Other department is also getting involved in the program. Many states, they have very innovative campaigns. They have done innovative campaigns for past 7 to 8 years to bring the message to the people. And next, the most important intervention what we have now is the prevention of leprosy among contacts. So in the high endemic areas, a tool which can prevent the leprosy among contacts will be helpful. So in that way, we give a single dose of rifampicin to the close contacts. So that is the one which is available in the program, single dose rifampicin. The other things are in the project mode or in the trial, maybe which will be put into use after an evidence-based research actually. So we have single dose rifampicin, which can prevent around 57% transmission in the contacts. So rifampicin is given in double doses, so that is also tried out. So which is 57% effective. So we tried to increase that 57 to 90% by addition of a second drug, moxifloxacin with rifampicin. So that is also in the trial mode. Next, third, why not vaccines actually? BCG is actually protective. Introduction of MDT and BCG is actually caused the burden, reduction in our burden actually. So based on the Mycobacterium species, we have this Mycobacterium indicis pranae vaccine, which is an immunotherapeutic vaccine also, and also immunoprophylactic vaccine also. So that will be also helpful in preventing the transmission of leprosy. And now we have the reporting system. Previously, it was all paper-based, and now we have the NICUS 2.0, where we have a case-based, individual case-based reporting and real-time monitoring of the patients, where we can have a better decision-making process. So only by NLEP, a vertical program, so we cannot go much deeper. So we use the other programs also. We leverage the other programs under NHM so that we can have a comprehensive screening efforts. One thing under the Ayushman Bharat, we have this community-based assessment checklist. 30% population are screened. In that questionnaire on leprosy is also there. They are screened for leprosy also. The other important thing here is the RBSK, where the child cases, detection of child cases play a bigger role in the school health program previously. And we are also converged with Rashtriya Kishore Swasthya Karyakram also. So we converge with other programs. We converge with mental health program. And now we are converged with the NTPA also. So we converge with other programs in maximizing our output for the detection of leprosy cases. So these are the other things. The resistance to the primary drugs is actually less. It is less than 2% in the program. But still, we are establishing the surveillance network for antimicrobial resistance. We have a guidelines also. Now we have integrated because we know that the persons affected with leprosy have more number of mental health issues actually. So we have integrated NLEP with National Mental Health Program also with provision of services. Like AFP surveillance, we investigate each and every case of grade 2 deformity for the reasons for deformity, why they have reported late. And special focus for the high priority districts, we have 121 districts with prevalence more than 1. So we are concentrating on those high priority districts to bring it the level less than 1. Repealing of laws and continuous capacity building of the healthcare workers is also most important intervention what we have in the program. So this is the COVID, what we have seen. So definitely there is a reduction of more than 50% in most of the states. So there was a backlog of cases during the COVID period. So when we have to detect those cases in the mission mode, so LCDC was again relaunched. So we are catching up the cases which were there during the COVID period. Next, coming to the National Strategic Plan 2023, we move on to the next level. So to accelerate our interrupting the transmission, we have launched this National Strategic Plan and Roadmap for Leprosy with the specific objectives of strengthening the leadership and partnership and all, accelerating the case detection by active measures and by passive surveillance, the provision of services to a very quality level, provision of MDT, DPMO services, and social benefits, prevention of disease, disabilities. So that is one of the strategic pillar in our program, and digitalization in the form of NICOS. So with that, we move on to the vision of leprosy-free India. Here it is means the zero infection, M-Lepre, zero disease, zero stigma, and zero discrimination due to leprosy. So these are the interventions which has been planned based on the annual new case detection and grade 2 deformity, where the red ones, they will have twice a LCDC, leprosy case detection, and targeted interventions like contact screening and PEP, the first leprosy awareness campaign, grade 2 investigations. The green are the ones where the burden is actually low, new case detection is less, grade 2 deformity is also less. So they can go for the passive surveillance, increasing the passive surveillance activities, sustaining the surveillance activities, and targeted case detection like contact screening and all, and integration with other programs. So this is the one which we have prioritized the districts and also the blocks also, the lowest level of the districts also into high priority blocks, highest priority, high, moderate, and low priority blocks. So based on that, we are instituting our strategies. So this is our indicators which we try to achieve by 2027. That is the period 23 to 27, where 50% reduction in the case numbers by 27. So that was the target in the NSP. And the total number of districts with zero indigenous cases. So the locally occurred cases actually from 35 to 120, we have to increase. Then zero cases in leprosy by 350. And child cases with G2D, we have to reduce by nearly 90%. So that was the targets or the impact indicators which has been kept in the program. So one thing which has been, I have been asked over the years by the students or the doctors also is, so we have achieved elimination of leprosy. So that means even doctors also ask that there is no case of leprosy. Even Chengalpattu, where I have worked also, they would ask that whether leprosy cases are there. Yeah, definitely leprosy cases are there. District of Chengalpattu also reports around 70 to 80 cases in a year. So that is the scenario with the health professionals also. The thing is that elimination we have reached as a public health problem. That means one number or a target has been kept by the agency and we have achieved the target. So the target is actually less than 1 per 10,000 population. So we have achieved the target, but we are required to maintain the target and we move on to the next level of elimination. So elimination of transmission. Public health problem, it has been achieved. Next, we move on to elimination of transmission. So that is called the interruption of transmission. The transmission has to be cut off or transmission has to be interrupted so that no new cases of leprosy are occurring. So that is the one which is happening in other diseases also. Elimination of polio, that is the same thing where we don't have cases, transmission of interrupted, and other neglected tropical diseases also, it is the one which is targeted. Elimination of transmission or interruption of transmission. So we need to go to this level. So when we reach that there is no transmission, then we achieve a level of zero new case of leprosy. So that is the definition for this, from elimination as public health problem to elimination of transmission. So we are moving on to the phase of elimination of transmission of leprosy. So how does that actually work out? So these are all have to be quantified in some form. So you know that neglected tropical diseases, here everything is in slow motion. Mycobacterium leprae or leprosy, everything is in slow motion. Incubation period is long. So as like other neglected tropical diseases, elimination of leprosy will also occur in stages. We have to move by stage, and it is based on the detection of new locally occurred cases. So when there is local transmission is not there, so that are the one we are targeting among the child and adult cases. The first one is when you say interruption of transmission is actually occurred. So interruption is occurred when there is no child cases for 5 consecutive years. So the child year means less than 15 years. We don't have a case of child for the 5 years. So then we can safely say that there is an interruption of transmission. But that has to be done after a thorough check, and that has to be validated by an external agency also. So for 5 consecutive years, if there is no child case, so then we can say that interruption of transmission has occurred. That has to be at the block level, district and state level. Next, we move on to the next level of elimination of leprosy. So from interruption, next adult cases are not there for the 3 years. So total 8 years, we don't have child case, we don't have any case of leprosy for the next 3 years. So total 8 years. Then we can say that elimination of leprosy has achieved. Then we move on to the next level of post-elimination. Because incubation period is long, we have to have surveillance where the average incubation is 5 to 7. It may take up to 20 years also. We have to keep in surveillance for more than 10 years. That's the post-elimination phase. After post-elimination phase, then move on to the next level of eradication of leprosy. So this is how we move in terms of leprosy, disease control, elimination, and eradication. So that we are applying to leprosy also. So coming to the roadmap or other strategies, definitely we are reporting the cases, but the clustering of cases is it is different in different scenarios, geographical locations. So we have mapping of hotspot or clusters based on GIS mapping, and we have targeted intervention of these areas who are at risk actually. Then we are mapping the historically endemic clusters also. Active search is actually happening in those endemic clusters or high risk groups. The surveillance of leprosy has to be strengthened, active or passive. Existing health system has to be strengthened to detect a case of leprosy. For that, we have to sustain the expertise for the case detection and management of cases also. Next, we have this chemoprophylaxis, where we have to scale up the contact screening, and optimum level of coverage of this post-exposure prophylaxis has to be achieved. Timely and referral linkages from a block, village level to the block to the district, then to the tertiary care hospital or medical colleges. So strengthening our disability activities, increasing the awareness. Various forms has been created, but that should go in a form of behavior change. Then only the people will come out with a patch or other signs and symptoms. They should report to the health center. So that way we have to increase our self-reporting or voluntary reporting. Then we have improvement of socioeconomic conditions also, where Swachh Bharat Mission and other housing programs are there, where we are leveraging on that thing also. Leprosy is notifiable disease. Still, it is not a notifiable disease like TB. And we are the government is making efforts to make leprosy as a notifiable disease, so that all cases which are reported is to the program. Partnership with stakeholders, sustaining the efforts. So these are the things which are already available. So we have reached a level at these things. So we need some newer diagnostic tests to detect an infection. Say suppose a point of care test to diagnose infection in a subclinical stage, a point of care to diagnose the disease, the PB or MB. So that will be very helpful to the program and improved or better drug regimens. We have 6 months and 12 months of treatment. It is difficult for the patients to take for that longer duration. So improved drug regimen will also help in reducing the burden more. So these are the various strategies which is there to eliminate the transmission of leprosy. So these are the things which you have seen. So that's one. So life is left in them. A person affected with leprosy, art is left within them, song is left within them, dance is left within them. So bigger, they can be what you call productive member to the society if they are seen as a compassionate one, or we are providing all the efforts and the stigma part is not there. So with that, we try to change this leprosy from a old one with this what we see as the disability or patches to one very beautiful new face of leprosy, which we want to see as a very productive members of the society. So with that, I hope I have justified to the thing. Thank you for your kind attention. And as said by Sir also, our father of nation, his leprosy is close to heart. Even before introduction of this Dapsone 1940s, he was nursing the patients. People now also think that by putting in alms or giving money to a person affected with leprosy who is actually asking the alms, people think that I will get leprosy. He nursed the patients when a treatment was not there. Dapsone was not there before 1940s. So that was his thinking, that leprosy will not transmit that much easily. So that was our father of nation. So in his memory, we are commemorating our National Anti-Leprosy Day today and continuing our efforts. So World Leprosy Day, actually it is on January 24th. In India, we commemorate on January 30th. We also have a separate theme like ending discrimination, ensuring dignity. So with that, together we can make a difference as young professionals. So still leprosy exists in some forms, or where every 5 minutes one case is detected. So we have to unite to eliminate leprosy and to reduce the stigma and discrimination. So thank you. If you have any additional materials, resources are available on cltri.gov.in. The manuals are available for medical officers, health supervisors and all. Even if you have additional queries, you can write to mail IDs. Thank you. So this is the CLTRI Chengalpattu where I have worked previously. Thank you.
Thank you, sir, for the valuable insights on India's progress on leprosy eradication. I take this opportunity to thank sir for the elaborate presentation. I request all the participants to post your queries in the chat box. The queries will be addressed at the end of the session during the Q&A session. Now, moving forward, let me introduce Dr. Lathika VR, who serves as the Deputy DMO of Kozhikode District, and she is in charge of NLEP in the district. She has a wealth of field experience in leprosy control and rehabilitation done in the district. Ma'am did her undergraduation from Government Medical College Thrissur and MD in Community Medicine from Government Medical College Kozhikode. As a NLEP in charge of the district, she has been instrumental in implementing the latest national strategic plan. Today, she will guide us through local challenges and strategic interventions, a ground level analysis of leprosy in Kerala. Over to you, ma'am.
Thank you, sir, for inviting me for this session. Most of the presentation, my presentation, elaborated by Kumaresan sir. I am also a student of Kumaresan sir in Chengalpattu while attending a training program. Next slide. I will be describing the scenario of case scenarios in Kerala. Up to December 2025, we have reported 302 cases of majority, 255 cases are multibacillary. Cumulative cases on treatment is 527 cases are on treatment now. Our prevalence rate of the state is 0.13. Next slide. This is a district-wise case scenario. 302 cases are reported last year from April to December 2025. Only 58 migrants. Most of them are native cases only. Next slide. 19 child cases reported in Kerala last year. Next. This is the representation, slide represent grade 2 deformity cases. 38 cases are of grade 2 deformity. Most of them In Palakkad, 12 cases are reported. This indicates late detection. Next. Our state achievement in SDG target prevalence, we have achieved only 0.13. We have to achieve below 0.1 rate. Child case of leprosy 0.53. We have achieved the SDG target. Grade 2 deformity cases, our rate is 1.05. We have to reduce it to 1 per million. Next. This slide also is described very well. We have to achieve the non-endemic status by 2030 by WHO. Next. This is the interruption of transmission achieved blocks in Kerala state. Out of which, last slide. Kozhikode, we have achieved 13 blocks. Ernakulam, 13 blocks. Kottayam, 13 blocks. Alappuzha, 13 blocks are achieved interruption of transmission. That is, last 5 years, there were no child cases in these blocks. Next. Mainly in our district, and passive case detection is mainly occurring. Voluntary reporting by the patient to the OPDs and private hospitals. Also in general OPD and dermatology OPD of medical colleges. Active case detection mainly occurring by the campaign mode and routine mode also. Routine means field workers while visiting houses, etc. In January, we have leprosy case detection campaign that is Ashwamedham 7.0 in Kerala. We also do focus leprosy campaign, special camps in tribal area, coastal areas also. Asha-based surveillance of for leprosy suspects. Absence also occurring. We also do epidemiological investigation of grade 2 deformity cases within 90 days also. We also do contact tracing and follow-up of contacts for 5 years. We also release from treatment. We follow for the 5 years. Next. This is that slide representing the LCDC leprosy case detection campaign data in Kozhikode district. In January, Ashwamedham campaign, we detected 3 cases. 2 of them are migrants and 1 native case only. Next. In Kerala, we conducted 2 rounds of Balamitra to detect cases in children. Screening mainly. Screening the 3 to 18 age group children. We conducted in 2021 and 2023 also. Next. We focus mainly on IEC to decrease the stigma and discrimination in of the leprosy affected persons. Also making aware the free availability of multi-drug therapy in PHCs in government sector, freely available. Also, leprosy affected patients for reconstructive surgeries are done freely. Next. We also do financial assistance to patients, ASHA incentives for detecting the suspected cases from village and also for completing the treatment. ASHA is also doing the cases, follow-up of cases and motivate the self-care practices and also spread awareness among community. During the Sparsh campaign, we also do mainly social awareness campaigns are done through social medias. Video bites of dignitaries are spread through social media. We also do scrolling news in local channels. Next. Sparsh campaign and leprosy fortnight from January 30 to February 12. Also, we do the ELSA campaign. Services are also available through eSanjeevani OPD portal also. Next. This is a SWOT analysis of leprosy program. Currently, we have an opportunity of existing healthcare infrastructure. By capacity building of them, we can improve the program. Also, we reporting through the IHIP, also HMIS also reporting through the ASHA is happening. Also do Shaili survey. In Shaili survey, leprosy is also included. Major threat of the program is stigma and discrimination to the leprosy patient. It is.
Sir, I have a question.
Area-specific strategies are to be done depending upon the geographic situation. While outbreaks, etc., happening, leprosy is also a sideline program. This is a major threat of the program. Next. Thank you.
Thank you, ma'am, for that enlightening session, which gave us the latest breakdown of the state of as well as the state of nation. With that, come to the end of the sessions. Now, we open the floor. Participants are requested to post queries in chat box. What is the status of recent research in leprosy? Are we missing something? Can you address this question?
Hello. Now, your question is now. Please repeat the question. It is not audible.
Okay, sir. So, the question is status of recent research in leprosy. Are we missing something? Kumaresan, sir?
Yes. Status of research in leprosy.
Yes, sir.
Yeah. So research is happening all over the world. Still, funding is also there for leprosy. But to put into the resources for a disease with a burden of where you see that 170,000 cases all over the world, the priority differs. But still, the organizations which are working in leprosy from the past, they are continuing the research. Only thing is that the research has not yielded the outcomes actually. So the bacteria itself is enigmatic one. Various epidemiological concerns is also there. Whatever has been put out, where we could not get that kind of outcome. But still, research is there. State and research where this point of care test, it is also done in post-exposure prophylaxis with rifampicin and addition of fluoroquinolones to reducing the burden. In terms of vaccine is also research is happening. So research is happening at the institutions where they are working for leprosy for long. It is there, but it has reduced actually. As a student, those who are put, you can have interest in that and you can pursue those. I actually invite you young minds actually to come for this national cause and support research in leprosy.
Thank you, sir. The next question is, what are the next strategies to be followed, especially in border areas?
Border areas. Border areas actually problem is there when there is a high endemic or the low endemic border areas within where I have seen the cross movement of cases from Tamil Nadu to Pondicherry, Puducherry, where tertiary care hospital is there. So there is a border area. We have conducted one border meeting with the district officers of the two districts and also the state. A coordination meeting will do your planning for these border areas. One thing, and we can have a nodal officers from the both sides for the case reporting and cross movement of the cases where there is a continuous follow-up of the cases. We can have the nodal officers also, and we can have special screenings also for the migrant population or the mobile population where they move from the other side of the borders, and the checkposts or transit points like what we use in the IPPI and other programs which is happening, so that points can be targeted. Outreach sessions can be also targeted for the border areas, and the mobile units can also run a proper coordination with the both units with the other state also. A proper coordination, the frequent coordination meeting will ease the procedures in the reporting the border areas. I think so.
Thank you, sir. There are few more questions. How can we frame a plan for reducing a stigma in our community?
Yeah,
Is there
stigma.
stigma present?
Yeah, stigma is the major cause of discrimination in leprosy, and it's happening by the deformities which it causes. So one thing is by reducing the deformity, we are reducing the stigma to a greater level. One thing, and next is the enhanced BCC. IEC we have done a lot from 1950s, from 75 years we are doing the IEC campaigns, but the voluntary reporting has actually not improved. So what we need at the community level is some innovative behavior change communication. So like a breast self-examination. So that was there where they come out with the self-reporting. So a kind of thing like it should be for leprosy also for the case reduction. So behavior change activities will reduce the stigma, and we should have some influences for that thing, where an ambassador or influencers, religious leaders, community level leaders, teachers. So they spread the message of the right kind of message of leprosy, because people have misconception regarding leprosy. So it is a highly transmissible disease. Even if I touch, I will get leprosy. Still, it is there in the minds of people. So those kind of thoughts has to be thrown out. So for that, awareness activity in full, it needs to be there. Empowerment of persons affected with leprosy. We have seen in the past where the loss was also there, where a person affected with leprosy is thrown out of the jobs, even government jobs also. So leprosy was a contagious disease, so they could not remain in the jobs. But now we have come to a situation where the person affected with leprosy with 40% disability, they are given employment in the 1% quota for persons with disabilities. So they are mainstreamed into the program. They are into the job, and there is no stigma in that part if they are mainstream persons affected with leprosy, if they are empowered, if they are and mainstreamed. And media, definitely media plays a role. A good media communication, it will bring the right kind of messages, and the political commitment, the social support. You have to get more in reducing the stigma in the community. So that's some measures which can reduce the stigma. Even medical students, they have to be what you call taught on these aspects.
Thank you, sir, for answering that query. There is another query. Is there any relation between leprosy and social class, geography, climatic conditions?
Yes, climatic conditions play a role. Some I could see one question where northeast or some high altitude regions where they have less of leprosy. Definitely, these high altitude regions have a less number of cases. We could see it may be because the bacteria itself is a very temperature sensitive bacteria. It gets more propagation, multiplication in 27 to 30 degrees. Below that, it multiplication gets difficult actually. So in high altitude, one thing is the temperature plays a role, and the lower density in the higher altitudes in the northeast or other parts, there is a density is actually low, which where the close contact is not there for the transmission of leprosy. And in the extreme cold weather, our body also adapts actually. So usually this bacteria grows in the colder parts of the body. So when we get adapted in the very cold sensitive areas, so it further extreme cold actually it lowers the temperature in our bodies also. So in that way, I think so. In the high altitudes, these are some mechanisms: geographical, temperature, humidity also plays a role in the high altitude areas for leprosy to be less in those areas, specifically northeast, or even you could see that in Nilgiris, Ooty, and other high altitude areas. So climate plays a role definitely in propagation of leprosy. And next, I could see that while those beggars, migrants, any targeted approach. So it is not common actually. It is not common about beggars. So because of the leprosy, they are actually made into beggars actually. Because leprosy, they are thrown out of their families. They don't have a productive life. They don't have any means of income actually. So somehow they have to support themselves. So they take this easy path of begging. So it is the other way around. Because of leprosy, they go into the begging habit. So that has actually happened. And migrants definitely, the government of India now under the program is taking up the case detection among the migrants. A special approach is there for the migrants. We could see that many states are doing a special case detection among the migrants, industrial clusters, wherever they are more. And if the case detection is there, close contacts, their contacts are traced in their respective districts or the states also. So a targeted approach is there, but program has not come up with a different one. Maybe in future, in the program also, we'll have a separate strategy for migrants. But still now it is not there in the program. But many states are doing that. Treatment regimen for children below 9 years. 9 years, up to 9 years, we have this blister calendar fixed dose combinations. Whereas below 9 years, we go for the dose range. Rifampicin is 10 milligram per kg, and dapsone according to the body weight. We prefer the dosage for children below 9 years. Dosage combinations are also available. Why government is unable to declare it's a notifiable disease? Because notifiable disease, to make it into a notifiable disease, it is a big process where it has go through different kinds of communications, guidelines and all. Many states have made it a notifiable disease under their state public health laws. Government of India is also working on that now for the notifiable disease. Undernourishment, definitely nutrition plays a role where immunity, the cell-mediated immunity plays a bigger role in the transmission from infection to disease actually. It plays a role here where this lesser immunity, infection, if it is there, the immunity plays a role in what they call flare-up of the disease actually, into a disease, infection to disease. When our immunity is actually good, then it goes to the self-healing more, and this infection, it will not develop into a disease. Definitely, nutrition plays a role in this undernourishment. I hope I have answered most of the queries.
Sir, 2 more questions is there.
Yes.
Could you please answer?
Yeah, please.
Yes, sir. Is there any other programs like Ashwamedham in other states with a very high burden of cases?
Yeah, Ashwamedham is in Kerala. They have a separate name, and all the states are conducting this leprosy case detection campaign. Now, recently, most of the states are going for 2 rounds actually in a year. Tamil Nadu also recently they have completed 1 round, and high burden states are Chhattisgarh. I have visited Chhattisgarh every year. Last 2 to 3 years, I have visited Chhattisgarh. They are conducting leprosy case detection campaigns. I have visited Karnataka. I have visited other states, Maharashtra also, for this leprosy case detection campaign monitoring programs. So all the states, these high endemic states where the case reporting is more, they do this leprosy case detection campaign in the form of what you call Ashwamedham, but in their different names.
So thank you, sir. One more query is there. What are the challenges we are facing in eliminating the disease? And what are the other activities done other than LCDC?
I covered in the program, I covered in my slide also. One thing is the strategies. Coming to the strategies, challenges faced. So challenge is that when I am touring to the district, actually, that persons at the health centers actually. So still the capacity or the skills to diagnose a case of leprosy is actually lacking, because they what you call the what the mind does not know, the eyes does not see. So we should have that skill building exercise. It is purely a clinical diagnosis. Whenever a skin hyperpatch is there, the first thing which has gone to is the testing of the sensation. That is true with leprosy. So expertise at all the levels, at the block level, PHC level, block, and not all has to be trained. At least one expertise has to be there for diagnosing a case of leprosy. That expertise has to be retained at the field level or the block level for the detection of cases. That is one challenge which we see, because the case numbers is reducing. Many undergraduate students, they don't see a case of leprosy also. So in that scenario, to diagnose it will be difficult. So skill building is the most important challenge which we see. So that continuous programs are done, capacity building programs are done, and it is a hidden burden. How to get the case diagnosed. So that is actually a challenge, and we don't have any test also for diagnosing an infection and the disease. So that is a major challenge what we face. And misconceptions of leprosy. So to tackle that misconceptions, so that is one of the challenge. And one I asked about these entities actually. So it is grouped under a neglected tropical disease. So after 2005, when the program is existing, the resources also dwindled, the manpower also dwindled, where there was a separate manpower. So now there is no separate manpower for NLEP. So resources actually reduced for leprosy also, and manpower issues are there. So these are some challenges which are faced at the field level.
Sir, about the LCDC, any other activities other than
LCDC is a major program. So this is one form which is done for 2 weeks. Like LCDC, what we have this focus leprosy campaign. Whenever a grade 2 deformity is detected, we do surveys actually. So that is focus leprosy campaign. And this is the contact screening. So this are one form where there is an active screening, targeted screening. So LCDs is one targeted screening for particular period of you go for screening. Focus leprosy campaign is where LCD is not there. You do this when a grade 2 deformity, or some states they say whenever a case of leprosy is reported, they do surveys in their villages actually. So some states are following low endemic states. The contact screening is again a very good targeted interventions, and case detection among children in the form of RBSK. RBSK team is trained for detection of cases among children. So that is a very good initiative. So then special leprosy awareness campaign, by creating awareness, and during that period, we are going for case detection activities also. So these are some initiatives which are there in the program.
Thank you, sir. Last question for the day. Is there any specific format for grade 2 deformity detection?
Grade 2 deformity detection, for the investigation of grade 2 deformity, there is a specific format. We have a monthly reporting format for the cases, grade 2 deformity children. All we have a monthly reporting format, which is from the PHC level to the block level. For investigation of grade 2 deformity, we have a specific format for that.
Okay, sir. One more question. Whether in India is leprosy considered as NTD?
Yeah, not only in North India, all the countries, leprosy is considered as an entity. It is one of the entity among these 19 or 20 groupings actually. So it is a neglected tropical disease. It means the disease is neglected in terms of resources, in terms of expertise, and other things. So these cross-cutting diseases actually they affect a major population where morbidity is actually more with these entities. And the entities, why the grouping is that there is a what you call the screening, the surveillance, and the other treatment part. More or less, many entities we have the skin entities. They have a cross-cutting mechanism among the skin entities and other entities. So they are grouped under this diverse group of entities. Leprosy is a neglected tropical disease, not only in India, world over, as by WHO.
Thank you, sir. That was the last question for the day. Thank you so much. Now, one question is there from Lathika ma'am.
Yeah.
Ma'am?
Yes. Yes, madam.
So the question is, can you please explain the activities done during the month of Jan 2026?
Jan 2026.
No. To Lathika ma'am, sir. The question was asked.
Yeah, okay. Yeah, thank you.
In January, we have a round of leprosy case detection campaign named Ashwamedham 7.0. And we have currently in Sparsh campaign also, January 30 to February 12.
Thank you, ma'am. So with that, we come to end of Q&A. As we wrap up today's webinar, I'm moving on to the vote of thanks. I express my gratitude to all who made this event possible. First, our sincere thanks to our principal and management at KMCT Medical College for their unwavering support. A special thank you to our resource person, Dr. K Kumaresan sir and Dr. Lathika ma'am for sharing their expertise and providing us with clarity on the zero leprosy target. I also wish to thank Dr. Jayakrishnan sir and the Department of Community Medicine for their meticulous planning and bringing forward this webinar. Finally, to the delegates, your active participation proves that the medical community is committed to making leprosy-free India a reality. Let us remember the theme for 2026, leprosy is curable. The real challenge is stigma. So thank you all. I wish everyone a very happy weekend ahead. I request all the participants to kindly fill the feedback forms shared in the chat box. Also, a recorded video will be shared in our official YouTube channel. So kindly join the WhatsApp group for the link. With that, we come to the end of today's session.